short video is going to be covering a few divergences of the lower leg and knee. Specifically, in this video, we're going to cover Tibial Vara, Genu Varum, Genu Valgum, and Genu Recurvatum. So the first one we're going to cover is Tibial Vara. If you think about the words, what's going on here, remember we covered the forefoot and the rear foot varus and valgus in our foot and ankle unit. Now we're just going to be applying the same terms to the tibia. So what we're going to see here is a bowing towards the middle of the tibia. Another name for this tibial vara is this Blount's disease. So what's happening here in this tibial vara most often, I'm sure that there's other scenarios in play, but what's happening here most often is we're going to have a growth plate disturbance. So in the growth plate, you're going to have excessive growth on the lateral side of the tibia. And then you're going to have disrupted growth on the medial side. And maybe even, I'll say this, maybe you even have normal growth on the lateral side of the tibia, but again, disrupted growth on the medial side. So if you think about what's going to happen there, you're going to create an extended bone on the lateral side, which is then going to push it medially, if you can imagine that, if you can visualize that in your mind. So you're going to grow on this side, which will push that medially. So here's a few more images of it. So this is going to cause bowing, specifically in that tibia. And it'll be tough to recognize here. Notice the distance between the knees. This is going to look very similar to a Genu Varum. However, with tibia vara, it's specifically happening at the tibia as opposed to happening throughout the knee. In 60% of cases, it affects both legs. However, there are instances where it may only affect one. Most frequently found in kids. So a couple causes of this tibia vara, I'm sure that there's many others, but the ones that are listed here in this PowerPoint and in this slides, they talked about specifically childhood obesity, short stature, or some very, very early walking, which contributes, again, to that growth plate disturbance on that medial side. And here's some etiology that you can read through if you so choose to. And I'll skip on. Getting into a little bit of the correction surgery. So with the correction surgery, this is an external fixator here, but what you can see, what I want you to appreciate, this surgery is going to be very, very invasive, and I would anticipate that they would either hope to do it when a person's done growing if it's not bad enough, right? If a person can function normally, if they can wait till they're done growing, I'm sure that's ideal. If not, they're going to use this external fixator to constantly correct for growth disturbances throughout childhood, right, as the person grows. But what they're going to go and do, they're going to separate the medial portion of the bone there, which is going to contribute to or cause growth, right? Those osteoblasts are going to come in and they're going to form. And then hopefully they will be able to catch up the medial and lateral side, equating to an equal tibia. So again, this is going to be very invasive. It's going to be very problematic for the person. I'm sure at every instance they try to avoid it. And it's only when a person has their life so severely affected that they have to go in and do this. I assume that that's when they would take that opportunity. So we're going to move into the Genu Varum here, aka bowing of the legs. So you can see, I wanted to point that out. This is going to look similar to that tibia vara. However, we're going to see increased distance between the knees, and then we're actually going to notice this beginning through the femurs. And then we're going to create this bowing. Okay? So when you evaluate this posturally, you'll have someone stand with their ankles together, and you'll notice the increased gapping and a little bit of the angle deviation. And as we do this in class, hopefully you can get the chance to see, someone without Genu Varum, and you'll appreciate that their knees are going to come together and be really close to touching, if not touching. And then the increased space, we would call it Genu Varum, and then there's, severities of that, or increased distances. So moving on down, Genu Varum can potentially contribute to pathology. It doesn't always contribute to pathology, but in certain instances, it might. We probably all know someone that has a little bit of Genu Varum, and they probably live their life just normally without any problems, and it's not a big deal. However, in some instances, if someone has enough of a Genu Varum, what they can do is they actually create concavities and convexities in their legs, which is going to contribute to compression and then stretching. So in this Genu Varum, they're going to be compressing the medial side of the knee, and they're going to be stretching that lateral part. This white that you can see here on this radiograph, that's increased bone growth, or new bone growth, maybe is a better way to say that. So this person has enough of a Genu Varum that it's really compressing that medial compartment, and their body is going through remodeling in hopes to rebuild this because it's starting to destroy the bone. So if someone experiences, they have enough of a Genu Varum that they are really experiencing some osteoarthritis, specifically in that medial compartment of the knee, they want to receive some relief. For example, in this instance here, you can see the closed down distance here and the increased gap on this lateral side. They can do a hemi-arthroplasty, so this is a half knee replacement. And you can see they're just going to do it on that medial knee. So that's a potential solution for someone with a really problematic Genu Varum that's really disrupting their day-to-day life, where they can just fix that medial compartment. One more note here about Genu Varum. When you watch your young kids that your nieces, your nephews, or your neighbors, or what have you, you'll notice if you were to watch my daughter walk around actually right now, she's just under a year and a half, these little kids are going to experience this Genu Varum pretty naturally. Remember, this Genu Varum that the kids are doing is to help increase their stability. You'll notice here at the end of life, we do the same thing, right? As we increase in age, we're going to increase that Genu Varum again because it helps us feel more stable. Throughout this middle part is where we really have our narrow stance. You'll even notice here in this 3, 4, 5, 6-year-old range, you might even notice that these young toddlers, they'll actually run around and they'll develop a little bit of a Genu Valgum, which is the knock knee. So you can kind of see that progression throughout life as a person, continues to develop and they're just they're trying to be functionally the best that they can be. So kind of an interesting thought there. So now we're going to move into this Genu Valgum. This is the exact opposite of the Genu Varum. So this is knee knock, right? The knees are going to come together and touch. The feet will be distanced apart. So you can see this is a nice image here. This is going to be a really severe case of a Genu Valgum. So the feet are really distanced here. Here in the United States, this would get caught, I think, fairly early, and there would probably be some attempted corrections made. But there may be instances where this is just the result of the person's genetics, and it is what it is. So a couple of these causes, there's just a couple listed here. There are so many potential causes. Again, we probably, I would feel comfortable. We probably know someone, or we know someone that knows someone that has a little bit of this Genu Valgum, and it's not a big deal and it doesn't affect their life. But, in some certain instances it could be growth disturbances. So maybe that medial compartment of the knee is really growing while the lateral compartment isn't growing very much. Maybe they had some trauma. Maybe they had some trauma. Maybe they disrupted their growth plate on the lateral part of the knee. Maybe they took a blow or whatever. And then maybe they, rickets vitamin D could certainly be a contributor. I think another one that we see sometimes is maybe cerebral palsy or some other things where the person has some muscle spasticity through the adductors, but they keep their feet wide again to help them achieve some stability and some balance. So I think there's many causes, and it's probably pretty individual person to person. So here in this image, we're going to be just the exact opposite of our Genu Varum. So in our Genu Valgum, we're going to be compressing the lateral compartment of the knee, and we're stretching the medial compartment. So that MCL is going to be stretched. You can see the hemiarthroplasty on this individual in that lateral compartment as a result of their Genu Valgum. And last one that we're going to cover here, Genu Recurvatum. Genu Recurvatum is a extended curvature of the legs while a person is standing straight. In our class, chances are we will see someone with a Genu Recurvatum. Again, probably not a big deal usually. A quick Google search, these images are really interesting. I had to stare at them for a while to figure out what's going on. In fact, a quick Google search of some Genu Recurvatum pulled up some really interesting things. You can see this infant and that Genu Recurvatum. There was another image, this one here. I don't know what happened here. Maybe it was a fracture or something. Oh yeah, femoral fracture in children, which contributed to a Genu Recurvatum. So anyway, a quick Google search pulled up some interesting images of this Genu Recurvatum. Anyway, we'll keep going. So Genu Recurvatum, I want you to glean from this slide. If someone has Genu Recurvatum, if you're doing a postural analysis, make sure you do a lateral view. If you only do an anterior view, you may mistake a Genu Recurvatum actually for a Genu Vara, right? This person has their feet together and you see some increased distance in their knees. However, as the person moves their legs back and they go more and more into this recurvatum, those knees will spread further and further apart. So if you're doing a postural assessment, just make sure you do a thorough one. Take a view from the lateral view, take a view from the anterior view, and then that will help confirm that you're actually seeing a Genu Recurvatum or a Genu Varum. Here's an image here, some Genu Recurvatum there, and we'll keep going. So, you know, if someone has enough of a Genu Recurvatum and it's contributing to some pathology or some problems in their life, what do we do? So it's actually kind of interesting, but one of the things that we can do that's so simple and effective is we can simply use a heel lift. And you may notice that this, you know, next time you see someone in high heels, or, you know, if you own some high heels, you can throw them on and notice this. But when you're in, if you give someone a heel lift, they actually, it's, from what I understand, it's very hard for them to go and lock their knees out. It's more comfortable for them to maintain a slight knee bent posture. And so we utilize that. We can utilize that idea. We give someone a slight heel lift, and it's going to encourage that person to keep that knee bent and not go back into that Genu Recurvatum. Instances where we might want to limit this recurvatum, maybe these people are really stretching out the posterior capsule of their leg, or maybe they're impinging the anterior structures in their knee. So maybe they're getting some pain in their anterior knee, or maybe they're just developing total weakness on the posterior side because they're constantly in this state. So those are instances where we might utilize this heel lift to limit the amount of Genu Recurvatum for that person. And that will actually wrap up this video for these divergences of the knee.